Welcome to This Explainer. Today, we're unlocking what I like to call the mind's medicine cabinet. Now, psychopharmacology can often feel like this dense, totally intimidating maze of giant chemical names and complex interactions. But at its core, it's about something deeply human, the pursuit of the Goldilocks brain. We're looking at how psychiatric drugs try to find just the exact right balance of chemicals to relieve some really profound suffering. So whether you're a student, a medical professional, or just someone fascinated by how our brains tick, my goal today is to totally demystify this science. We're going to break down these tools to see exactly how they work, why a doctor chooses them, and what risks they actually carry. Let's dive in.
So, here's how we're going to navigate this giant alphabet soup of medications today. We'll start with antidepressants, move into antipsychotics, then mood stabilizers, talk a bit about calming minds and boosting memory, and finally, look at what happens when we go beyond pills.
All right, part 1, antidepressants. Let's look at how these drugs actually lift the mood. Now, if there's one number you need to remember here, it's 70%. Across the board, most antidepressants have a remarkably similar response rate of about 70%. But, and this is a massive but, it takes real patience from everyone involved. You absolutely cannot tell if a trial has failed after just a few days. We're talking 4 to 6 solid weeks on a full dose, just to see if the treatment is actually working. It's a slow, steady climb, not some magical overnight fix. Okay, so if they all work about the same, how on earth does a doctor pick one? Well, it entirely comes down to the trade-off of side effects and half-lives. We're talking about SSRIs here, selective serotonin reuptake inhibitors. Take fluoxetine. It stays in the system a really long time. That's great because you can dose it weekly and it totally prevents those nasty withdrawal symptoms. But then contrast that right away with paroxetine. It has a short half-life, which means a notoriously high withdrawal risk if you miss even a single dose. Plus, it tends to cause weight gain. Or look at escitalopram. It's fantastic if you're taking multiple medications because it plays super nicely with other drugs. It's really all about matching the specific quirks of the drug to the patient's actual life. Now, SSRIs are generally super safe. They're our first-line treatment, but we've got to watch out for a severe system overload known as serotonin syndrome. It's exactly what it sounds like. The brain basically gets flooded with way too much serotonin, usually when a patient mixes multiple serotoninogenic drugs. The symptoms escalate incredibly fast. We're talking fever, dripping with sweat, a racing heart, high blood pressure, delirium, and overactive reflexes. If this happens, it is a drop-everything medical emergency. You stop the drugs immediately and give an antidote called cyproheptadine to literally block those receptors.
To appreciate SSRIs, you really have to see where we came from. We used to rely heavily on older tricyclic antidepressants, or TCAs. And man, they were heavy-handed. They caused dangerous cardiac issues, severe sedation, and terrifyingly, they were lethal in overdose. Obviously a massive concern when you're treating patients with severe depression. The shift to SSRIs was an absolute game changer because they offer specific targeting. They do exactly what we want them to do with serotonin, making them significantly safer and just way easier to tolerate in everyday life.
Moving right along to Section 2, antipsychotics. Let's talk about clearing the mental static. Here is the ultimate trade-off in psychopharmacology. First-generation typical antipsychotics are fantastic at stopping psychotic symptoms by blocking dopamine, but they risk locking up the physical body. They carry a super high risk of movement disorders. Think Parkinsonism, severe rigidity, tremors. So medicine evolved, right? We got the second-generation atypicals. These cast a much wider net, blocking both dopamine and serotonin. That added serotonin action makes them way gentler on your body's movement. But there's a heavy cost. You risk massive weight gain and severe metabolic issues. You're basically trading a neurological side effect for a metabolic one. To truly grasp why doctors overwhelmingly shifted to those newer drugs, we have to talk about tardive dyskinesia, or TD. It is an absolutely devastating involuntary movement disorder caused primarily by those older typical antipsychotics. It shows up as these abnormal repetitive motions, especially around the face, mouth, and tongue. And the absolute tragedy here, the majority of these cases are entirely permanent. They're irreversible, even long after you completely stop taking the drug. And being older or being female puts patients at an even higher risk. There's another huge emergency we have to watch like a hawk when prescribing any antipsychotic. Neuroleptic malignant syndrome, or NMS. Kind of like serotonin syndrome, it's an explosive, life-threatening reaction. The hallmarks here are extreme fever, severe muscle rigidity, altered mental status, and just wild, unpredictable swings in heart rate and blood pressure. NMS is no joke.
it carries a terrifying 20% mortality rate. The second you see it, you stop the medication and get that patient intensive, hospital-level supportive care.
Now, within that second generation, there's a really fascinating outlier, clozapine. It's a total paradox. On one hand, it is statistically more effective than every other antipsychotic on the market. It's the absolute go-to for cases that just won't respond to anything else. And amazingly, it's the only antipsychotic definitively proven to actually decrease the risk of suicide. So, why isn't it the first choice for everyone? The severe risks. Clozapine demands incredibly strict monitoring because it can cause a life-threatening drop in white blood cells, something called agranulocytosis. Plus, it carries risks of heart inflammation and seizures. It's an unbelievably powerful, life-saving tool, but you have to immensely respect it.
All right, part 3, mood stabilizers, finding that perfect balance. When we're talking about mood stabilizers, lithium is the undisputed gold standard. It is the drug of choice for acute classical mania, and it's one of the rare treatments proven to reduce suicidality. But lithium requires walking a very, very delicate tightrope. The therapeutic index, which is just the window where the drug works without poisoning you, is unbelievably narrow. It sits perfectly right between 0.6 and 1.2 milliequivalents per liter. You literally have to constantly monitor the patient's blood to make sure they stay in that tiny, precise zone. Because that window is so tight, it is incredibly easy to accidentally tip over the edge into lithium toxicity. At a normal therapeutic level, you might just have a fine hand tremor or feel a bit slow cognitively. But let's say you get dehydrated, or go on a low-salt diet, or even just pop some common ibuprofen. Your levels can spike. That fine tremor becomes coarse. You start vomiting. Your mental status gets totally foggy. Push those levels even higher, and it turns lethal, leading to convulsions, coma, and death. Highly effective? Absolutely. But the margin of error is literally paper thin. So when lithium isn't an option, what do doctors do? They turn to alternative mood stabilizers, which are actually often repurposed anti-seizure meds. And they each bring their own weird clinical quirks. Carbamazepine, for instance, literally induces its own metabolism in the liver. So doctors have to keep bumping up the dose early on just to keep the blood levels steady. Then there's lamotrigine. It's absolutely brilliant for treating bipolar depression, but you have to increase the dose at a snail's pace. If you rush it, you risk triggering Stevens-Johnson syndrome, which is a severe, life-threatening skin rash. Let's jump into Section 4, calming minds and boosting memory. For things like immediate anxiety and agitation, we frequently rely on benzodiazepines to turn up the brain's natural calming system. But you definitely don't just grab one at random. The half-life dictates the exact clinical scenario. Long-acting benzos, like diazepam, are perfect for slowly and safely bringing someone down during alcohol detox. But if someone is having a sudden panic attack, you'd want an intermediate one like alprazolam. You probably know it as Xanax. It kicks in super fast and wears off much quicker. It's an exercise in precision timing, though we really have to watch out for massive risks of physical dependence and tolerance over time. In that exact same medicine drawer, we find our treatments for dementia. Now, we unfortunately don't have a cure yet, but we can slow the decline. In the early stages, we use medications like donepezil to protect acetylcholine. That's a neurotransmitter that's absolutely vital for forming memories. As the disease sadly progresses into moderate or severe stages, we might bring in a drug called memantine. This one targets the glutamate system to help preserve whatever brain function we can for as long as possible. And honestly, we often combine the two approaches for the best result. Okay, but this brings us to a major crossroads in our explainer. We've talked a whole lot about chemistry today, but what happens when the pills simply fail us? What do we do when a patient's depression is completely treatment-resistant, or they're totally catatonic, or the side effects from these pills are just way too severe for them to tolerate? That question leads us right to our fifth and final section, beyond pills, somatic treatments. The most famous and honestly the most historically misunderstood treatment here is electroconvulsive therapy, or ECT. You really need to forget what you've seen in the movies. Modern ECT is a highly controlled, incredibly life-saving medical procedure. It is a frontline option for severe depression, acute mania, or catatonia, especially when a patient is actively suicidal or stops eating. It uses targeted neuromodulation over a temporary course of sessions. And the amazing thing? Once the symptoms improve, the treatment completely stops. You might get some temporary muscle soreness or temporary amnesia, but that almost always clears right up once the sessions are done. We also have some incredible modern options like TMS, or transcranial magnetic stimulation. This is a fully FDA-approved therapy specifically for treatment-resistant depression. Instead of medication or inducing a seizure, TMS uses an electric current on the scalp to create a highly focused magnetic field. That field reaches just about 2 centimeters deep into the brain. By doing this over repeated 45-minute sessions, it directly stimulates the cortical interneurons. It basically wakes up the underactive areas of the brain responsible for mood regulation. And it does it without any of those full-body side effects you'd get from swallowing a pill.
Ultimately, what this whole explainer shows us is that psychopharmacology is this unbelievably nuanced balancing act. There's literally no one-size-fits-all magic pill. Every single decision, whether it's picking a long-acting SSRI, risking the metabolic effects of an antipsychotic, walking that tightrope with lithium, or trying a somatic therapy like TMS, it is all a calculated trade-off. It's about finding exactly what's just right to relieve suffering for each individual person. I really hope this helped clear up a profoundly complex topic for you. So as we close the medicine cabinet today, I want to leave you with this. Which specific tool or trade-off that we talked about today completely surprised you the most? Think about that, keep learning, and I'll catch you on the next explainer.